record on the important and long-standing topic of hospital understaffing. My name is Maria Raffinsky, and I am the former president of New Jersey Nurses Union, Communication Workers of America Local 1091, who represent 1,700 RNs and LPNs at Cooperman-Barnabas Medical Center, Monmouth Medical Center Southern Campus, and Barnabas Health Behavioral Health Center. Currently, I serve as co-chair of New Jersey Nurses Union and CWA, which represents approximately 20,000 members in New York and New Jersey. For the past 45 years, my entire career at the bedside as an RN, from the picket line to the bargaining table to the halls of our state capitol, our members and I have relentlessly been fighting for safe staffing because we know that safe staffing saves lives. This bill before the committee today represents a pivotal moment for safe staffing in New Jersey. Our frontline staff have made selfless sacrifices during COVID-19 pandemic, and it is now far overdue that the state addresses the issue of safe staffing, protecting patients and our healthcare workers alike. The devastating consequences of understaffing exacerbated by COVID-19 can be seen in the mortality rates. There are significant disparities in mortality rates between hospitals that are well-resourced and hospitals that are not. According to the data collected and analyzed by the New York Times, patients at hospitals with lower staffing rates were three times more likely to die than patients in better staffed and resourced medical centers. Short staffing should not be the standard by which our hospitals and facilities operate. While the pandemic stretched our hospital system to the point we were not prepared for, many of the staffing issues are long-standing issues that were exacerbated by COVID-19. While this bill symbolizes a huge step in the right direction, enforcement of the ratios is imperative. Staffing complaints filed with the Department of Health are followed by the Department of Health inspections at the reported facilities. These inspections are vital to the enforcement of the ratios. They provide a deeper dive into the details of the short-staffed shift or shifts that were reported. In NJNU's experience with these Department of Health complaints, our facility was cited more than once, and remediation was mandated and left up to the hospital to implement. It is clear that this model of hospital self-enforcement does not work. The fines and new enforcement tools in the bill will motivate hospitals to remain in compliance. The hospitals that do have no additional exposure. Establishing the Patient Protection and Staffing Fund will result in the enforcement of fines being redirected for the recruitment, retention, and training of nurses and Department of Health inspection staff. The sponsors have rightly directed any enforcement revenue back to the fighting the problem at its source. Additionally, we need real worker input, nursing, bedside nurses, throughout the entirety of this process. We look forward to working closely with legislators, our members, and all those affected by short staffing to make sure that we get this legislation passed. I have brought current staffing forms from bedside nurses with me here today. This is about one of 50 binders that we have in our offices. I would love to sit and go through many of them with you, but it would take days, if not weeks. I therefore submit any copies of the staffing forms that any of you would like to review after this committee meeting today, and I respectfully submit those. Thank you for the chairman and committee members for allowing me to share my experiences on this issue. The acuity of the patients today than when I started 45 years ago is exponentially higher. The comorbidities are so much higher, so the patients are complicated. You're seeing patients that used to be in critical care maybe 40 years ago, they're on the floors now. And a bedside nurse on a medical floor is taking care of 6, 7, 8 patients, probably 7 and 8 at night. Hopefully during the daytime you have 6. Recently we discussed a lot about working at the top of our license. That's a new phrase that has come this past few years. Basically saying that nurses should be working at the top of their license. We can't. When we're running to the pharmacy, when we're helping somebody to the bathroom because we don't have enough nurses' aides, when we're help transporting someone, when we're fulfilling all those standards that we are now tasked with. So the acuity has gotten up here, but our staffing has still stayed here. And in critical care itself, we should never be tripled, ever. I'm a critical care nurse. You would not want your family member in a critical care assignment, 3 critical care patients. The technology alone has become so complicated, and these nurses are, all of our nurses are highly skilled, but the technology has gotten much more intense along with these patients. And in critical care, it should never be 3 patients. And in some cases, it should be 1-to-1, as Judy said about different equipment that they have. And they don't want to put 1-to-1 in the contract. They'll only say something like, oh, extreme acuity. But it needs to be defined. It needs to be adhered to.